becomes dead or apoptosis. That is why there is a notion that diabetes is a progressive disorder. Gradually we lose our beta cells over years and ultimately person is dependent on insulin. But the belief is now that it becomes de-differentiated. Instead of getting dysfunctional and dead, it becomes de-differentiated, goes back into the cellular line and pretends as if it is not a beta cell and protects itself from the stress and saves itself and waits for a conducive environment to again differentiate and perform its functions. Now, the thing is that the question is what triggers this de-differentiation? Can this be aborted, reversed, and what is the right time to intervene? Now, let us first see that what is the factors which cause this de-differentiation. So, there are progenitor cells, and these cells have got transcription and translational factors. Some of the importance which have been more studied upon is in front of you, some of which I will be talking about. And this differentiation involves a coordinated and tightly controlled activation and or repression of specific transcription factors. There are transcription factors which are either activated at proper time or they are repressed also. And downstream they affect the genes and a cluster of genes in a time-dependent manner, thereby giving rise to particular morphological and functional cellular features. Out of this FOXA2 is the most studied transcription factor. FOX and FOX protein A2, and it is involved with the differentiation of liver and pancreas. Now this FOXA2 has got a pivotal role in endoderm and gut tube formation, leads to patterning of posterior foregut into pancreatic endodermal cells and the pancreatic endocrine progenitor cells. Now this progenitor cell can be differentiated into either alpha cell or beta cell, and this will depend upon the balance between ARX and PAX4. These are also transcription factors. The transcription factor MAPA, this is very important, is required for mature beta cell phenotype. And if this MAPA is depleted, then the beta cell loses its phenotype and doesn't function well. Now FOXO1 regulates expression of NeuroD1 and MAPA, needed for insulin gene expression. And continued expression of NeuroD1, MAPA and FOXO1 is needed for maintaining the identity of mature beta cells. Now what is the cell fate and the reprogramming needs, and let us see what are the epigenetic changes. Bremse et al. Noted that alpha cells have beta cell genes in poised chromatin state, and there are two factors, one is activating, one is repressing. And treatment by histone methyltransferase inhibitors induced expression of beta cell specific transcription factor PDX in alpha cells. So you can even transform alpha cell into beta cell by certain activation factors. Now what are the epigenetic factors? We all know that we are living in an era of nutrient overload. This nutrient overload leads to translocation of cytoplasmic FOXO1 into nucleus. Why? Because this translocation of FOXO1 into nucleus will upregulate the production of MAPA and NeuroD1, which is needed for insulin gene expression. Because when there is a nutrient overload, there is a stress for more insulin, more genes are to be activated for beta cell upregulation and insulin secretion. But the nuclear FOXO1 has limited stability. This leads to depletion of FOXO1, and once the FOXO1 is depleted because of excess stress, the beta cell de-differentiates. It loses its phenotype and physiological function and goes back into the cellular line and pretends as if it is not a beta cell, so that it can be protected from apoptosis and remains there in a dormant state till a conducive environment is there. Now this polyform complex PRC2 is another factor which is involved in gene silencing and maintains beta cell phenotype by silencing islet progenitor gene cells, as well as genes encoding transcription factors which inhibit expression of beta cell specific transcription factors. Now this polyform PRC2 has been studied in mice, and it has been shown that the mice deficient in beta cell specific PRC2 develop IgD in 16 weeks and over diabetes in 25 weeks. And oxidative stress and nutrient overload leads to decrease in beta cell specific PRC2. Now this is the usual, again the same story, that there is a functional beta cell, there is genetic predisposition for cellular stress. When there is cellular stress, either it can die or it can become dysfunctional or become de-differentiated, and when there is a condition it can become de-differentiated to form the functional beta cell. Now, this is a very quote from Yajurved, Yatha Pinde Tatha Brahmande Tatha Pinde. Means as is the cosmos, so is the pind, as is the pind, so is the cosmos. So for a fetus, the cosmos is the intrauterine environment. So by studying the intrauterine environment, you can predict what the pind will have qualities. And similarly, by studying the epigenetic factors in a given socio-economic condition, you can predict what will be the metabolic health of that pind living in that environment. And by studying the metabolic health of a pind, you can extrapolate what epigenetic factors are surrounding that pind. So this is very important. So can this dedifferentiation be aborted, reversed, and what is the right time to intervene? Now developing new drugs acting on various transforming factors is the new window which has been opened up, and using this knowledge of differentiation and dedifferentiation in current treatment algorithm can play a role in the future. Now this is a quote from Sushruta Nidan, Sarv eva pramehastu kalin apratikarana madhumehatvam ayanti tada asadhyata bhavanti. What does this mean? It means कि सभी प्रकार के प्रमेय means pre-diabetes, यदि समय पर ठीक प्रकार से उपचारित न किए जाएं तो पूर्णतया मधुमेह में परिवर्तित होकर असाध्य हो जाते हैं. तो आयुर्वेदिक नॉलेज सेज दैट इट इज असाध्य, जड़ से ठीक होने का कोई बात ही नहीं कि आयुर्वेद में, तो कहा यह असाध्य है. तो व्हाट इज द राइट टाइम? प्रमेय की अवस्था में ही प्री डायबिटीज में यदि आप इंटरव्यू कर ले जाए तो दैट इज द राइट टाइम टू इंटरव्यू. And all types of prameya, if not treated timely, finally gets fixed as diabetes and becomes incurable. So what are the indirect evidences of reversal or remission or dedifferentiation of beta cells from various clinical studies? I would like to quote 3 important lifestyle intervention studies and what were the results and how long does it work. The DPP and DPPOS, Daching and FDPS, they showed that at the end of the study, there was 58% reduction from conversion of pre-diabetes to diabetes in DPP, DPPOS, Daching 51, FDPS 58. 10 years later, it was 34, 43 and 43, almost similar results. And DPPOS, after 15 years, 27% reduction. So timely intervention does play a role and gives you long-term dividends. And the thing which was noted in all these studies was that the weight reduction was found to be the most important element of this risk reduction, means nutrient offloading the nutrient overload. Now in the newly diagnosed diabetes also studies have been done using short-term insulin therapy, 12 weeks therapy, and what 2 to 3 weeks therapy. And what was the result? It was that 42 to 69% remained euglycemic for 12 months or more on diet alone. So intervening at the very beginning with a very tight control, making the milieu nutrient overload free can give you a 42 to 69% euglycemia for 12 months. And beta cell functions were restored to normal with first phase insulin release secretion. It was again done with insulin compared to OHA. Again 2 to 3 weeks study, and what was the result? The intensive insulin arm, the other arm was given gliclazide or metformin. Target was fasting 110, PPG 144. 92% subjects in both arms achieved the target in average 8 days. And we take 3 months, 6 months to reach the target. They achieved in 8 days. Treatment was withdrawn after 2 weeks. And what was the result? Immediately after withdrawing treatment, first phase insulin secretion was similar in both arms. After 1 year, remission in insulin group was 51% and OHA group was 27%. So even by using OHA also, you can put the patient into remission if you are using it at the right time, in the right dose, and you are bringing the milieu interior of the cells very rapidly to normoglycemia. These short-term intensive glycemic control studies demonstrated that rapidly bringing the milieu interior of beta cells helps in bringing back the functioning to normal properly by offloading the nutrient overload affecting FOXO1, PRC2 and other transcription factors. Now studies done on the long-term diabetes. One study I will quote, the bariatric surgery study, sampling study, in which the average duration of diabetes was 8 years and the average HbA1c was 9%. Which we take it as now it is incurable, you will have to take insulin lifelong. In this study, what they found was that change in HbA1c was greatest with the gastric bypass surgery, and the weight loss was also greatest with the gastric bypass surgery. And the 10-year weight loss after gastric bypass, more than 20% weight loss, 71%, more than 30%, 39%, and within 5% of baseline weight, 55.5%. The results of bariatric surgery on long duration of diabetes population points out that probably in long-standing diabetes also beta cell mass is not lost, it is not apoptosed. Rather, it goes into dedifferentiation and they are shunned and they are in a dedifferentiated state. So a robust loss of weight more than 20% can revive these dedifferentiated beta cells and cause remission. The last study I will share with you is the direct study, which is a very low calorie diet study done in Britain, and this also showed that the weight gain or obesity is the main driver of type 2 diabetes, and 15 kg weight loss on 450 kilocalorie diet normalize beta cell function and pancreatic fat. And 15 kg intestinal loss might normalize life expectancy with type 2 diabetes. And we take type 2 as a cardiovascular equivalent. But it can normalize the life expectancy if you eat less. And remission by 12 months weight loss in that population, more than 10 kg weight loss, 73% are in remission. So this is a very important message. So can this dedifferentiated be aborted, reversed? And right time to intervene, I have already said you that it is the right time is the pre-diabetes stage, but even in the later stages, 10 years of diabetes, 9 years of diabetes, if you intervene, you get the benefit. So it can be done at any time, sooner the better, because in late stages one will have to undertake more complex procedures like bariatric surgery. So this new insight about sulfate, that is differentiation, dedifferentiation, will hopefully come with some novel molecules acting on target transforming factors. And our Prime Minister has something to say that towards a fit and healthy India, combating obesity, that is the nutrient overload. He has learned that, but we are still not learning it. And we are not doing our duty to propagate this message into the general population. But probably since he has intervened, we will get some results. और अभी एक लेटेस्ट ये न्यूज़ है, मधुमेह से जंग सभी विद्यालयों में लगेंगे शुगर बोर्ड. दिस इज फॉर द सीबीएसई बोर्ड स्कूल्स, कि वो जो भी इनके कैंटीन में सामान होगा उसमें शुगर कंटेंट कितना है वो उनको डिस्प्ले करना है. तो मेकिंग अवेयर द एडोलेसेंट इज द मोस्ट इम्पॉर्टेंट टारगेट वी शुड focus if we want to defy the targets given by IDF after 25 years or 35 years. If we work today on a people of 15 to 20 years, we will defy that target. So, work out, stop eating so much, keep diabetes out. Thank you very much. जब जागो तब सवेरा सूर्योदय होगा तो कुछ ना कुछ आपको अच्छा मिलेगा. Thank you so much.
Yes, sir. A beautiful presentation. At the end of the day, obesity, overweight, we have to take care of it. We have to motivate and educate the people. Session is open for discussion.
Good morning.
Thank you for the wonderful talk. But why no mention of GLP-1 and GIP talk?
Time is very less.
That is why.
That is why. My main focus was to just to convey the message that most of the beta cells are not apoptosed. They are silent, they are dormant, they are dedifferentiated. हमारे भोजपुरी में सर एक शब्द इस्तेमाल होता है, पता नहीं कितने लोग समझेंगे, घाटिया जाना. मैंने आपसे कोई काम कहा गया, आपने अनसुना कर दिया, आपने सुना ही नहीं उसको. तो बीटा सेल्स को वही काम करता, कहता मैं बीटा सेल हूँ ही नहीं, मुझे काम ही नहीं करना, तो मरने से अच्छा ना कि मैं चुपचाप किनारे पड़ा था. तो हमको लगता था सब मर गए, लेकिन मरे नहीं, वो सब शांत पड़ गए. So GLP-1 is also what it will do. It will do weight loss.
No, any role of GLP, GIP on the beta cell, because they say that they prevent beta cell apoptosis. So it's not just weight loss, it's also because we see GLP-1s working in type 2 diabetes whom we've been presuming have no insulin now.
That is still a topic of more research, more knowledge, but the main thing is that it is causing weight loss. And weight loss is very, because in direct study they use no drug. Only weight loss could lead to that much of remission. Stop the drug. You again have the same. So you will have to act on your diet and your nutrient overload. Finally.
Yes. Thank you, sir.
Thank you so much, sir.
So we move on to the next topic. May I invite Dr. Mukhya Pranab Prabhu to speak on genetic predisposition and epigenetics in diabetes prevention. So he is a professor and head of Department of General Medicine in Manipal. Over to you, sir, with this short introduction.
Thank you, sir. Good morning to everybody. At the outset, I would like to thank Professor Patni and others for organizing DRW, and they have given me unique topic, genetics and epigenetics in diabetes. Respected chairperson, the topic is vast. I will try to cover as much as possible. So, if you see that volunteer who is a French novelist and sorry, what we say is a comedian, he said, art of medicine consists of amusing the patient by nature cures the disease. What does it mean? It is in your gene. But what our William Master told, that it is astonishing with how literally doctor can practice medicine, but it is not astonishing how badly he made you. Means there are new knowledge is coming. Genetics is one of the things which probably as a doctors we have to read and implement it. So, it is in your gene, we have to do research and find out how we can prevent diabetes. So another greatest, Louis Thomas, who is a geneticist, he told, he is a physician, also poet also, greatest single achievement of nature to date was surely the invention of molecular DNA. So everything is in our gene, but what we have to do is how we can prevent it. So this is my outline of presentation of some definitions and what is the role in type 1, type 2, gestational MODY and prevention diabetes trial made a mass, but I think I also will not be going in detail, conclusion as fast as possible. So if you see that what is genetics, it's a Gregor Mendel who invented that term and the term was used by William Batson. He used it very well as a what is the genetical work based on Mendel's. What is epigenetics? It's a definition of a study of heritable changes in the gene expression not attributable to changes in the DNA expression or methylation. There are three things: DNA methylation, histone modification, non-coding origin. Means it is not easy to prevent genetic disease. So some of these things which have got which can be modified by genetic mechanism possible or dietary or environmental factors. So if you see that what James Noel told, diabetes is the genetic's nightmare. Because if you see that there are so many genes which have been implicated, your GWA study showed so many genes. If you see that this is a genetic syndrome associated with systematic review, so diabetes is divided into monogenic diabetes, what we say is MODY, and polygenic. Type 1 is diabetes is considered as autoimmune, but also there is polygenic inheritance. And if you see the gestational diabetes, there are so many factors like obesity, weight gain, polypregnancy. Type 2 diabetes is classically polygenic inheritance. Then there is a LADA and type 1 diabetes. If you see that monogenic, non-syndromic neonatal diabetes occurs before 6 months, non-syndromic maturity onset diabetes, what we consider as a MODY, now 2 to 5% of the diabetes, then transient diabetes. If you see that phenotypic and genotypic diabetes is divided into. What we are thinking is genetic diabetic subtypes can be, these are the genes which have been described. MTNR, I won't go in detail because the name itself will take time. Obesity related genes, FTO, MC4R, NRNX3, lipodystrophy related genes. These are the things which probably are our target. PPARJ, IRS, insulin resistance gene, lipid metabolism. These are the genes which probably is what we have to look for future studies to prevent the diabetes. This is again the classification: neonatal, MODY, syndromic, lipodystrophy. There we cannot do much. We can also only diagnose. Mitochondrial diabetes, it's a syndrome where you can diagnose. So these are the where gene environment interaction occur. Monogenic, where you can disrupt by cloning. The MODY we can detect by 25,000 tests we can detect. A genome-wide association study so many genes. I think more than 1,000 genes have been detected. Exome and genomic sequencing where you can detect rare variants. So diabetes is a pandemic, or what you say, there are so many things which is probably we know is only our metabolic factor. There is a genetic factors. Diet and lifestyle are the two things probably which can prevent the diabetes. So type 1 diabetes, as of you know, autoimmune disease, HLA linkage, so various things. There are some monogenic forms also. Then genetic component has been proved by the monozygotic twins have got more commonly, and thripty gene hypothesis which was described, which is one of the mechanism probably where you get save the energy for the family. So, but again it is not proved. Genomic thripty gene and also phenomic genotype has been described. Type 1 has got the strongest genetic component. But again, it is a HLA related, chromosome 6. Type 2 is again is a very complex disease, polygenic inheritance. There are so many things, beta cell dysfunction, peripheral insulin resistance, and again type 2 and rare form of Mendelian resistance related to observed deficiency can lead to hypoglycemia over a period of time. These are all the methods where you can detect, concentrate on pancreas for human sequencing of the genes, where you can concentrate and detect whether it can be genetically manipulated. Again, these are the sites where you can see, look at the pancreas, these are the sites where you can target your gene therapy. So again, this is a classification of Modi, we all of us know, I will not go into that. It forms, earlier it was not known when a person is diabetic at 25 years, is it type 1, type 2, this will help us to treatment at least. So therefore most of them respond well to sulfonylurea. Early age, less than 25 years, and again 2 generations of diabetes. That is the strong distinct. Hyperglycemia can be corrected by diet or a small dose of sulfonylurea. So these are various genes. Again, 14 types have been described, and Professor Mohan has described one more latest variety. So again, as I told, one study showed ABCA gene detection, which will be again early life diabetes can be detected. And again, type 2 diabetes, as I told, there are so many components, which most important is polygenic and multifactorial. Most important factor is our lifestyle and weight gain, which are been discussed. So genetic effects, insulin secretion decreases, insulin resistance increases, fatty acid levels go up, environmental factors. So again, thrifty genotype, which has been all discussed, I will not go into detail. So higher concordance in monozygotic compared to dizygotic twins, late age of onset, polygenic inheritance, multifactorial inheritance. These are various studies going on in polygenic inheritance of type 2 diabetes, but it's very difficult to pick up what genes. So there is a difficult because diabetes is so common and the genes are so many, you cannot target the polygenic inheritance of type 2 diabetes. These are the various challenges. Difficult to define phenotype, reduced penetrance, variable age of onset, failure to replicate finding, gene identified as small effects. Again, these are the various genes which I have found out. PPRK gamma is the most important, where the insulin resistance, we have got PPR gamma inhibitors. ABC8, KC8 genes have been detected, TCF11 has been detected. Some new genes have been detected with the recent studies, FTO chromosome 16 and chromosome 10. These are the new genes which have been detected by newer studies. Again, these are probably our targets for future prevention or treatment of targets. Identify individuals high risk of diabetes and diet related to it. So is it genetics useful? Probably it is helpful. As I told, we have to study further and know can it be used to prevent the diabetes. Presently it's mainly useful in the research basis. These are the various genes with young onset of diabetes in Asian Indian associated with a low measured genetically determined beta cell function. These are some of the studies from Chandak and some of the studies from CSMD, and many studies have been done by Professor Mohan. So, as an Asian Indian phenotype, they have detected these many genes from the Mohan study. Various parts of the country, they have detected so many genes which have been seen in type 2 diabetic in India. Again, PPRJ is the most important gene. So, poor intrauterine blood, fecal malnutrition, followed by overnutrition in childhood. This is a known phenomena, but again, still there are doubts whether it is a true hypothesis. So, Asian Indian, thin fat Indian, we note all these things, ethnic and Udvig. So, we are thin, but our fat is in the abdomen. Lifestyle may be very relevant to us. Fourth is SIDD, MIRD, IROD, CIRD. These are all described by Professor Mohan. What is the characteristic based on the BMI, C-peptide, glycemic control, insulin requirement and miscellaneous. I will not go into detail. These are what various types have been described. Environmental component is very important. In type 1 there is an infection, but in type 2 our lifestyle and our diet. Gut microbiota is the new thing which is probably changing gut microbiota may play part significantly in type 2 diabetes. Epigenetics is again DNA methylation, non-coding. These are factors which are not transmitted, probably which are related to environment and our this thing which we can target to prevent diabetes. Again, it's a phenotype is what is important for us. Type 1 viral infection, autoimmunity. So we can target T cells destroying insulin producing beta cells. If you detect them early by GAD65 antibody, IA2 antibody, ZNT8 antibody positive patient, they have got a tendency to develop diabetes at the age of 5 to 15 years where we can target. Modern research, there are so many research studies are going on, which I will not be able to. Latest is integration of multi-omics, genomics, epigenomics, transcriptomics, personalized type 1 diabetes prevention. Okay, these are the various discoveries recently. These are all Asian Indian genotypes which have been described. There are about 10 multiplied by 10, 100. This is neonatal diabetes occurs in less than 6 years, and again it is a genetic, it's a monogenic. Initially they may go off the diabetes, later they may become diabetes. These are variants which are again described, including the PDX1, HbFN1 alpha, neonatal diabetes. Implication is that they may require insulin initially, later they may not require insulin. This is approach to diabetes. I will not go into that later. Mitochondrial diabetes has got a specific syndromic classification, which I will not go into detail. IPEX syndrome, these are all the syndromes associated with diabetes. Next generation DNA sequencing may be required. Is it diabetes preventable? My last part of question is type 1 diabetes and type 2, or is it preventable? Again, probably it is preventable if you detect risk factor. What is it? Pre-diabetes. Indians are highly prone for the pre-diabetes at this stage. Weight reduction, diet and other things can prevent the diabetes. Obesity, parents, age, these are the people which, this is Western, but Indian people are not less but thin, lean individuals. Maintaining normal weight is the most important. Then eating a healthy diet is the next important. Regular physical activity is the third thing. Smoking and other unhealthy habits to be prevented. Identify your diabetes risk from the Mohan's diabetes risk score. This is what is the Indian listing. Burden of pre-diabetes. These are all the various targets where pre-diabetes can be targeted. Again, insulin resistance or insulin secretion problem. So, if you see that various studies, MetaMask, weight reduction, will it help, drugs will prevent, they all have proved that lifestyle changes is the most important. Metformin is found to be useful, pioglitazone has been found to be useful, acarbose has been proved to influence. Even in type 2 diabetes, there are studies which showed that SGLT inhibitors and also probably GLP-1 analogs are helpful in prevention of diabetes. This is IDF initiated to prevent the diabetes. These are various studies, Deeping, Finis, DPP study, but the lifestyle will come above all. Effect of weight loss, medication, again, early start, fentormin, all have been, liraglutide has been tried to prevent the diabetes. It is proved to be successful, but not highly successful. I will coming to the other CTs. This is how it is, genetic predisposition, pre-diabetes, type 2 diabetes. Research is what is called monoclonal antibody. The patient is individual, they have tried. There is a diabetes and DICE study, diet and autoimmunity, and there is a study SGLT inhibitors used in type 1 diabetes. And again GLP-1, this is what you had asked, GLP-1 receptor are useful in the prevention of the type 1 diabetes. Type 2 diabetes already I have told, stop study. Okay, these are my references. Coming to endpoint, genetics in diabetes is challenging and exciting, gives hope for the future, whether we can prevent it. Monogenic forms of genetic, the genetic testing is useful to identify the which patient has got what type of diabetes. Type 2 diabetes is definitely proved to be polygenic, multiple factors and epigenetic influence is there. Targeted intervention in pre-diabetic stage and precision medicine may be the way forward. I would like to end with Albert Einstein, learn from yesterday, live for today, hope for tomorrow. So we hope that future we can prevent this dreaded disease. The important thing is not to stop questioning. We know that so many genes are there. Can we identify? I also think it's not possible. But don't stop questioning. Try to target one place, you may get this thing. Thank you for the patient listening.
It was a rapid fire thing, the entire topic of epigenetics in just 12 minutes. Thank you once again, sir. Just one question from the audience.
I have a question. Sir, I'm a part of a registry called YDR, Young Diabetes Registry. So, I have a loud voice. So, Young Diabetes Registry, and we have seen that the incidence of type 2, so we are registering anybody who developed diabetes less than age 25.
Yeah.
So in the past 10 years, we have seen a steep increase in type 2 diabetes in the younger than 25. So my question is, this is not genetics. Genetics can't change in 1 decade. So is there a genetic component? And what about epigenetics? How long does that take to manifest? Yeah. And environment, of course, we know. In the last 10 years, type 2 has increased.
Is it a part of ICMR exam?
Yes.
Okay. I think our center is also.
Yeah, we are also. So I've also seen that, or I'm seeing it because I'm in a metro like Delhi.
Yeah.
That I'm reporting more and more type 2 in the young. Yes, ICMR.
ICMR diabetes.
YDR, young diabetes.
Yes. Yeah. What I can tell is that when a person develops diabetes below 25, you have to probably, is it a type 1? You know that antibodies can be taken. If it is negative, very unlikely to be type 1. Then other part is that, is it a type 2 diabetes or is it a MODI? MODI, we have got genes, at least 14 types have been detected, and you can do genetic studies because many of these people may have a MODI, maybe 2 to 5% off, because if you say below 25 years diabetes and the C peptide is preserved, is it not what you told me?
No, my question is genetics important or can epigenetics translate?
Yeah, in these cases, first we have to characterize them. Is there a type 1, is it type 2 or is it MODI? Yeah, if it is not there, probably there is no way of genetic test you have to do to show that it is not MODI. Probably not type 1. These two things you have to do. Then it's early onset diabetes. Probably epigenetics, the weight loss, if they are obese. But MODI people will not have that type of this thing.
No, her question is how long does the epigenetic factor takes time?
No sir, that is not very clear. That is very not. DNA methylation, all these things, what is that? It's not clear. Will it help? How long it will help? That is all.
Generational.
Yeah, generational changes. So it is a generational changes of the DNA. It will not be 1 generation, 2 generation. It will to future this thing.
The question is how long it takes, but it takes a long.
No, they should follow again all the lifestyle continuously.
Next generation.
Exactly. If I am having some genetics or epigenetics,
Yeah,
whatever,
even if you have, it has to be done from generation to generation. It all has happened because of the
transgeneration, and depends on a lot of multiple factors, environmental, social, and lot of factors are there to just replicate it or aggravate it and this. That is the thing. What she wants to know. That was the question.
It's a generational.
Yeah. Not in a decade, but it is for a long years, but other social factors are there too.
So we may have to concentrate now, next 2-3 generations, it may affect. That's it.
Yes, sir.
Sir, I have one question. In your scenario, antibody test is difficult.
No, antibody test is available.
Antibody test is difficult, and genetic analysis is more difficult.
More difficult.
Then how can I differentiate between MODI type 1, 2, 3 clinically or in some?
No, sir. MODI, once you have got any diabetic less than 25 years, not clinically fitting into type 2, obesity is not there, autoimmune features are not there. Autoimmune testing you have to do. Because below 25, you have to do autoimmune testing definitely. Whether to do MODI testing, it costs about 25,000. Most of the genes can be done in Mohan Center. 25,000 you have to spend. If not, then you consider it. I think
If it is not fitting into what all you say, we can be very well sent to Dr. Vijay's center or Dr. Mohan Center.
It's nothing like that. His question was very clear that it is an issue, definitely cost is an issue.
Yeah.
But if you are suspicious of MODI, so let us be very clear that we have centers where you can put in this request.
Yeah.
You can do it for free of cost.
Yeah.
Number one. Number two, now the MODI, the whole package comes at only 15,000 rupees.
50,000.
Only 15. So there are centers there also. But how many percentage you are actually suspicious of MODI? That's very small.
Very small percentage.
That you can actually clinically
If the
evaluate
patient has got
whether they
a
can fall into MODI, and then you can always this.
If the person has got DKA, probably it's a type 1 diabetes, he requires lifelong insulin. If he is not requiring type insulin, he is surviving, then he is young, then he is not obese. 22 generations is there, suspect MODI. If possible, you do the genetic testing because patient will ask definitely.
Thank you, sir. We can go for the if that's up. Thank you, sir. Thank you, sir.
Doctor,
in the next speech on chronic inflammation as driver of diabetes-related complications.
He is a professor and senior consultant in geriatric and internal medicine, Apollo Multi-Speciality, Kolkata. He has various fellows to his credit and is a distinguished teacher and a speaker in various forums, and he was a chairman of scientific committee chairman for GISICON 2022.
Yeah, thank you, sir. Thank you. Good morning, all of you. Good morning, all the delegates. Good morning, all my chairpersons. It's a nice, pleasant weather at Calcutta today morning. Last 2 days it was very rain and water stagging in Calcutta, specifically Thursday and Friday. But today in the morning it is a very bright sun, good weather. So I am thankful to Dr. Vijay Patni sir and DRW for this platform. So as all we are diabetologists and working on the diabetes, and Dr. Prabhu is talking about this genetics and epigenetics. In this context, so the next good topic is the chronic inflammation as a driver for diabetes related complications, because diabetes itself is now gradually become day by day causing a lot of complications, specifically macrovascular and microvascular complications. And what we are noticing, the diabetes itself or the chronic inflammation works as a driver for all the diabetes related complications. So with this I am starting my topic today. So my topic has been divided into 3 modality. This presentation explores how chronic inflammation acts as a central mechanism behind this complication, worsening vascular damage and increasing morbidity and mortality in diabetic patients all over the world. The chronic inflammation, the root of vascular diabetic complications. As we all know, the diabetes affects more than 537 million adults worldwide, representing a global epidemic with serious health consequences. Among its most devastating effects are vascular complications, both microvascular as well as macrovascular. The microvascular complications are nephropathy, neuropathy and retinopathy, and macrovascular complications are chronic heart disease, peripheral vascular disease or cardiovascular stroke. The inflammatory mellow in diabetes, what are those? What happens in diabetes or in chronic inflammation basically? The hyperglycemia induced stress. If there is a high blood glucose, it causes oxidative stress and formation of advanced glycation end products, AGEs, which trigger inflammatory pathways. The AGEs are a group of heterogeneous molecules formed through a non-enzymatic glycation process known as the Maillard reactions. AGEs bind to the receptor for advanced glycation end products, RAISE, expressed on various cells, specifically the endothelial cells, monocytes and macrophages. And this binding activates key inflammatory pathways like NF-κB pathway, increases pro-inflammatory cytokines like TNF alpha, IL-6, IL-1B, and stimulates oxidative stress and endothelial dysfunction by inducing ROS, that is reactive oxygen species. And further, ROS causes enhanced AGE formation and VCS cycle is going on. This is a basic pathophysiology of chronic inflammation in any diabetic patient. So this is the basic. And with this, all this complication arises step by step and VCS cycle usually goes on. Next is the metabolic dysregulation. What is the metabolic dysregulation? Dyslipidemia increases inflammation through oxidized LDL and free fatty acid, while gut dysbiosis disrupts intestinal barriers promoting systemic inflammation. So in gut dysbiosis, leaky gut, lipopolysaccharides in blood, inflammation, insulin resistance and causes beta cell stress. Increase in branch chain amino acids and altered bile acids causes metabolic disruption, and in diabetes, the increased LDL, increased ox-LDL, macrophage uptake, foam cells, atherosclerosis, inflammation, insulin resistance, ultimately it causes worsening of the diabetes. So this is the thing, basic vicious cycles in chronic inflammation, and these things are going on with time and time, with decade and decade, and causes all the micro and macrovascular complications. So what happens? Inflammation and diabetes links. There occurs chronic inflammation in diabetes. It is a significant factor in the onset of type 1 and type 2 diabetics, affecting overall the health. Insulin resistance, inflammation disrupts the insulin signaling pathway, contributing to insulin resistance. Elevated cytokines in diabetes, which we are seeing nowadays from the research. There is a cytokine such as interleukin 6 and tumor necrosis factors are found in high levels in diabetic patients in comparison to the normal patient. Obesity and inflammation connections. This links between the obesity and inflammation is crucial in understanding the pathophysiology of diabetes. So key inflammatory mediators, who are these? Number one, the cytokines. What are the cytokines? Cytokines are interleukin-6, presence in the adipose tissue, liver and macrophages, tumor necrosis factor alpha, adipocytes and macrophages, interleukin-1b, macrophages and beta cells, resistance and MCP, monocyte chemoattractant protein 1. So these are the cytokines having a big role in diabetes, pathophysiology and chronic inflammation. Next is the chemokines and additions molecules. Chemokines are leptins, adiponectins, rentis. Pattern recognition receptors and downstream molecules, TLR4, NF-κB and NLRP3 inflammasomes. So these are the basic molecules which are responsible for this inflammation inside the body. Then the acute phase proteins. What are the acute phase proteins? Everybody knows about the C-reactive protein, CRP. Everybody knows about the serum amyloid. Reactive species, that is a ROS, reactive oxygen species, usually generated by the mitochondria, promotes oxidative stress and cytokine release. And nitric oxide, imbalance between the nitric oxide contributes to vascular dysfunction. So all are in the basic pathophysiology level, or you can say the biochemistry level and the basic. So what are the big complications? The microvascular complications, inflammation in actions. Everybody knows, each and every student from the first year to all the postgraduates, everybody knows the microvascular complications are broadly three. That is a diabetic nephropathy, retinopathy and neuropathy. What happens in diabetic nephropathy? Again I am telling, as it is a chronic inflammatory process for a long time and long years, what happens inside the kidney? If there is a chronic hyperglycemia, it causes glomerular hyperfiltration, endothelial dysfunction, activation of RAS, mesangial cell expansion, thickening of the GBM, mesangial matrix accumulation, glomerulosclerosis, proteinuria, progressive decline in GFR, chronic kidney disease and lastly end-stage renal disease. The contributory mechanism, again AGs bind to the AG, there occurs hemodynamic changes, increase the glomerular pressure from the hyperfiltration and RAS activation, there occurs oxidative stress and all this causes chronic kidney disease. Again the contributory mechanism, the cytokine involvement, fibrosis and podocyte injury. Next is the diabetic neuropathy. Again same thing happens over there. If there is a chronic hyperglycemia, there is increased polyol pathway activity, osmotic stress and oxidative stress, mitochondrial dysfunction, axonal damage and Schwann cell injury, decreased nerve conduction velocity and demyelination. And once the demyelination starts in the nerves, there occurs sensory, motor and autonomic nerve dysfunction. And what we are getting clinically, we are getting the clinical diabetic neuropathy. All of diabetologists, we treat the patient of diabetic neuropathy nowadays after 5-7 years of diabetes. What happens? Numbness, pain and gastroparesis. The same contributory mechanism, polyol pathway overactivity, oxidative stress, AGs and RAGE activation. Now come the diabetic retinopathy. Again there occurs inflammation inside the eyes. Again chronic hyperglycemia, increased polyol pathway, endothelial dysfunction and capillary basement membrane thickening, breakdown of blood retinal barrier, capillary leakage, formation of microaneurysm, retinal ischemia, hypoxia, neovascularization, hemorrhage, exudates, fibrosis, retinal detachment, ultimately patient will end up with visionless or blindness. So early intervention is very important in diabetic patients for prevention of diabetic retinopathy. So yearly checkup is very much important to see whether retina is how much involved and which stage of the retina is there. Contributory mechanism are almost same in the retinopathy, nephropathy and neuropathy. Now comes the macrovascular complications. The macrovascular complications, as we all know, coronary artery disease, CAD, peripheral vascular disease, PAD, or cerebrovascular disease or stroke. What happens over there? In CAD, the prevalence is the most common cause of death in people with diabetes after the age of 45 or you can say 50. The manifestations are stable angina, acute coronary syndrome, heart failure. The pathophysiology again, the hyperglycemia promotes AGEs which damage endothelial cells and promote oxidized LDL uptake by macrophage, formation of foam cells. There occurs insulin resistance and chronic inflammations due to the increase in the interleukin 6 and TNF alpha and CRP. Cerebrovascular disease, again the same pathophysiology works but in a different way. Peripheral arterial disease, again intermittent claudication, rest pain, non-healing ulcer, ischemia gray, major risk for lower extremity amputations. So underlying mechanism in all macrovascular complications and endothelial dysfunction, there is an age-range axis, oxidative stress, inflammatory cytokines, dyslipidemia and prothrombotic state. So clinical evidence, inflammatory markers and vascular disease, how we can predict? Do the simple CRP test. Elevated CRP predicts higher cardiovascular events with relative risk of 2 in diabetic patients. You can check the interleukin 6 in stroke patient. Tumor necrosis factor alpha in nephropathy. Anti-inflammatory benefits, meta-analysis shows anti-inflammatory drugs reduce cardiovascular complications. So research is going on with C-reactive protein, interleukin 6 and stroke relation, TNF and nephropathy. So diabetic complications and inflammation, if the CRP is gradually increasing, the complication is 2-fold more than normal population. So there are some animal models or you can say the experimental models because we all know about the nephropathy, neuropathy, micro and microvascular complications. What is the future? Because we are now in 2025, we should look about next 20 years or 25 years how we can give protection to our patients or how can we improve the science. So what are the animal models for this experimental proof? There is a genetic deletion studies, RAGE inhibitions, MCP1 and neuropathy and LRP3 inflammations. And they are more promising at this moment in the genetic as well as in the base root levels because NLRP3 inflammations targeting and LRP3 reduces retinal injury in diabetic animals, highlighting therapeutic potentials. Blocking RAGE signaling protects kidney from diabetic damage in rat models. So these are the basic, if we do work on these levels, we can give some protection to our next generation. Therapeutic implications, targeting inflammations. What we should target for the next lifestyle changes, Mediterranean diet lowers inflammation, smoking cessation. Today's World No Tobacco Day. We are observing all over the other pulmonologists are observing World No Tobacco Day and Government of India is also working No Tobacco Day. Today is 31st May. Regular exercise reduces systemic inflammatory markers. Then the pharmacological strategies. What is in our domain? In our domain from the doctor's point of view, 1 minute more sir. Statins provide anti-inflammatory benefits beyond the cholesterol control. AC inhibitors and ARB we are using since last long years for the basic protection. Emerging therapy which I was talking about, what we should target about? We should target about the interleukin, we should target about the RAG and we should target about the NLRP3 inflammations because of these are the new concept for the prevention or prevent the complications of diabetic patients at this, all the science is promoting on progressing on these aspects. If we can stop on that level, we can reduce the inflammation and complications further. So the chronic inflammation prevention, number 1, balanced diet, regular physical activity, stress management, nutrient-rich foods, anti-inflammatory diets, community programs, health education and weight management. So these are the basic things everybody knows. What are the challenges and future directions? That is very important because in any CME or any conferences, we should think about what next, what the challenges and what our future directions, what our students should know about us. What is the future direction? There is always individual variability. Targeted therapy should be included and needed. More selective anti-inflammatory agents are needed to minimize side effects and maximize efficacy. Role of the microbiome role, understanding the gut microbiome interaction could unlock new anti-inflammatory strategy. More research is going on at this level and further clinical trials are needed. So the innovative research direction, as a teacher and as a scientist, we should always think about the innovative research for our next generation and next category. Novel anti-inflammatory agents, investigating novel anti-inflammatory agents that could play a vital role in managing diabetes complications through the inflammation reduction. If we reduce the inflammation from the base level, further complication will reduce. Next most important research aspect is the gut microbes influence, exploring the gut microbe's significant role in modulating inflammation and its impact on overall metabolic health. And personalized medicine approach, because each and every patient is unique and we have to be personalized approach in management. What are the ongoing studies focus on personalized medicine to tailor inflammation targeting strategy based on genetic and lifestyle factors. Genetics, we was just talking, Dr. Prabhu was talking about the genetics. So these are the basic levels. Everybody knows about the medicines, everybody knows about it, but the baseline, if our base is strong, we can do more and more. So sir, inflammation impact on diabetes, last slide. Chronic inflammation is critical. Mechanism of inflammation we should look after. Importance of current research, more research should go, and holistic approach is required overall management of the complications. So in conclusion sir, there is a central role of inflammation. Chronic inflammation drives both micro and macrovascular diabetic complications. There is a therapeutic potential targeting the inflammatory pathways offers promising routes to reduce diabetic vascular disease burdens, and more research imperative should be there. Personalized anti-inflammatory intervention and deeper understanding of pathogenesis are critical future steps, and we should give more focus on that for prevent the diabetic complications. Thank you sir. Thank you.
Thank you sir. Thanks for the lucid presentation on this chronic inflammation. So just we are running short of time. We'll have your discussion at the.
Sure sir.
Thank you sir.
Yes sir. Now the final session, final topic by Dr. Kannan Natarajan from Chennai. He is a shining star, a dynamic and a vibrant speaker. Whatever complex topic is being given to him, he will simplify it, make it palatable. Over to Kannan. The topic is biomarkers for the early detection of diabetes. We would like to know from Kannan, at the end of the day, in the day-to-day clinical practice, what are the biomarkers are applicable in our day-to-day clinical practice? Over to Kannan.
Thank you, respected chairperson, for the wonderful introduction. And also like to thank our friend, our Dr. and also my friends. It's a great pleasure and honor to present this important topic before our President RSSA and also mentors our father and madam and our friends was there, Sambo and others. It's a great pleasure. So, dear friend, why this topic is very important? Because we know that there are different levels of prevention, primary prevention, secondary prevention. So these novel biomarkers play an important role at the level of primordial prevention, how to prevent pre-diabetes and how to prevent the complications from pre-diabetes to diabetes and also diabetes-related complications. So we are in the era of holistic care approach. We know that diabetes is a global burden with increasing morbidity and mortality, both macrovascular and microvascular complications. We know, with the emergence of modern medications, with the advent of modern medications like GLP, GIP and glucagon receptor agonism, tirzepatide and glutapatide are going to have, we know and emphasize how to prevent the complications, especially cardiorenal metabolic complications, but we don't know how to prevent the prevalence of pre-diabetes. That is very important. That is the area we want to consider, and therefore these biomarkers will play an important role in identifying the high-risk population, which population may lead for the pre-diabetes and which population may progress for the pre-diabetes and also prevention of the complication due to diabetes. That is called as the novel biomarkers. All these slides and data are derived from the science direct data and this Lancet data and also the annual index of medicines. The recent data emerged from the 21st century of the novel biomarkers. This is the definition given by our own Professor A. Ramachandran. What is the definition for the ideal biomarker? An ideal biomarker should refine the identification of those at risk of disease or progression, improve the prediction of complicated disease, and guide and help tailor responses to different therapies. This is very important. So, the biomarker in diabetes should not only prevent the complication, but we want to prevent the prevalence of pre-diabetes, and also we want to prevent the progression of pre-diabetes to diabetes, and also we want to mitigate and halt the complication among the diabetic population, both macrovascular and microvascular complications by means of various factors. We have genetic factor, genomic factor, proteomic factor, and so on and so forth. So this is the data given by Applied Neurosciences in a recent publication. This shows the predictive analysis and graphics, because we already know about the INSPIRE data. In INSPIRE data we have 4 clusters. Among the 4 clusters, some patient will go for microvascular complication, retinopathy and nephropathy. Some patient will not go for any complication. So we see in our clinical practice, so most of the patients will have sugar 250, 300, but doesn't have any complications. Because this graph shows that some patient will have the complication the first year, second year, third year, some patient doesn't have complication, even though the years pass away by 13 to 14 years, like heart failure, kidney failure, so on and so forth. What is the reason? Is there any biomarker, any gene biomarker like that, and so forth. So this is the data, important data, show the novel biomarkers to understand the cardiovascular complication, because they derived this biomarker, novel biomarkers, the case of the hominins approaches. They are derived from these sample populations, the high-risk populations, with these technological implement, because we are in the era of AI, Shambho is there, Shambho no, Sapratik is there, Sapratik tells us more on artificial intelligence also, along with Sasank Joshi. So this shows the omic approaches related with genomics, transcriptomics, proteomics, metabomics, lipidomics, and this derived from the blood, serum, plasma and urine, and it is information given to the AI model, and also we can derive from that this one technological thing, bioinformatics analysis can be validated, and also it is produced for the biomarkers development for the patients. So the ideal biomarker says highly sensitivity, predictability, robust, and more than that, there is early detection of diabetes, and also risk stratification is very important from the diabetes, from the high-risk population and also diabetic populations. So this is the timeline. So we can see the timeline prevalence of the biomarker, all the spectrum of diabetic prevalence, right from the risk factors, the primary prevention, pre-diabetes, or primary prevention diabetes, or secondary prevention also that as because we are a adiposopathy. We are in fact, Professor Yavli multiple times emphasized this. Adiposopathy is the main culprit. So we want to address the adiposopathy. The biomarker which is very relevant to the adipokines and hepatokines plays an important role to prevent the complication. So these data are given from the latest 21st century epidemiological data from biomarkers. These are the various biomarkers is available with our own traditional biomarkers. So these are the traditional biomarkers which are using right now in clinical practice: fasting sugar, cradle sugar, this one OGTT and the HbA1c, because these are gold standard, right? From 1980 they are replacing the HbA1c. HbA1c predicts the complication both macrovascular as well as microvascular, but it is more than the complication given by the FPG. So even the OGTT also, but there are some specificity sensitivity imbalances over there, because in some patients with the hemoglobin demand or sickle cell anemia or anemia, these things will not be utilized for the patient properly to identify the complications. So we need a good biomarker. So this glycated hemoglobin or OGTT or SLBG will be radio the diagnosis which patient, the fasting sugar, poor cradle sugar and overall HbA1c and all. It is a good diagnostic tool and a prognostic tool, but the complication prevention is very, very important. So this data given by A. Ramachandran, because you need this biomarker data in the IDPP, that is Indian Diabetes Prevention Program in 2002. He found that vitamin A plays a revolutionary novel biomarker for the early diabetes, because it's a great tool. This detects the metabolic dysfunction 5 years earlier and identifies the high insulin resistance before the glucose elevation and predicts the pre-diabetes and diabetes progression by 90% accuracy. Another novel biomarker is acetylcarnitine, that means the L-carnitine. These levels will be increased both in hepatic gluconeogenesis, and we easily identify both pre-diabetes as well as diabetes, and also prevent the complication, both macrovascular and microvascular complication. And more than that, there are some effective data over there. This L-carnitine is associated with the gestational diabetes and also early onset of type 2 diabetes onset, directly impairing the beta cell function. These are important things. Ceramides is a novel biomarker given by Professor V. Morgan. He did one of the biomarker data in their own study. Ceramides are lipid molecules, they accumulate in insulin resistant tissues. This induces the inflammation by means of this one tumor necrosis factor. Is an inflammatory model factor given by both pre-diabetes and diabetes. One of the novel biomarkers, netrin. It is a family of extracellular laminate. They express in the multiple areas over the CNS, endothelial tissues, liver and kidney. If you see the role in diabetes, netrin what is involved in pancreatic morphogenesis, islet cell migration as regeneration. So netrin also shows the promising markers for early detection and prognosis of the macroscopic complication, including retinopathy and nephropathy. So hydroxyprotein and GPC, these both important biomarkers combinedly, because combination is very, very important. One single biomarker will not be helpful. We have to give the multiple biomarkers like genomics, proteomics and transcriptomics, metabolomics. There are a lot of omics approaches. With these combination approaches, we can easily identify which patient going for complication at the pre-diabetes level, so that we can prevent the microscopic complication and also the macroscopic complication, especially heart failure. Adiponectin, Professor A. Ramachandran also did the important study in IDPP in 2002 and published in Lancet 2003. He published the data in ADA 2003. He found that adiponectin is one of the important resistant biomarker among the diabetes patient and the pre-diabetes population. So, adiponectin is a precious hormone from the adipose tissues, the adipokine, and also plays an important role as an anti-inflammatory and anti-atherogenic. And it found as a early detection of the the prevalence of insulin resistance among the thin patients as well as the obesity patients, so that it easily found both pre-diabetes as well as the diabetes populations. So these are the data given by Professor A. Ramachandran and published in 2003. Subjects with impaired IGT show the low adiponectin level. So this acts as an independent risk factor and independent biomarker in the prevalence of both pre-diabetes as well as the diabetes, and therefore the high level of adiponectin projects the glucose metabolism impairment in obese patient and decreases the risk of type 2 diabetes development, and level of adiponectin is found to be lower in type 2 diabetes and also obese subjects. One of the important data given by A. Ramachandran, once again, retinol binding A protein. This is nothing but the associated with insulin resistant development of metabolic syndrome. This is a combination of both adipokine and epitokine, and therapeutic target is understanding RP4 mechanism opens new opening for targeted intervention metabolic disease treatment both pre-diabetes as well as the diabetes population. We start in here once again by Professor AR. All the data given by AR. A. Ramachandran, so adipocytokine, demonstrates the revolution of adipokine and prevents both pre-diabetes, and you can easily evaluate the prevalence of pre-diabetes among the population with the high-risk population by means of genomic model as well as the metabolic model. Lipoprotein markers, previous speaker was telling more on these models, but we are often missing this lipoprotein A, because lipoprotein A is one of the independent risk factors among the diabetes and also cardiovascular risk patients, because less than that is not, because it's totally gene predominant. Maybe homozygous, maybe heterozygous hypercholesterolemia. So addressing LPA is very important among the diabetic population, because these individuals reach by 16.5 to 18.5%, and even though they have the proper LDL count less than 55, less than 40. So LPA is very important among the diabetic patient to rule out the inflammatory markers along with the triglyceride HDL also, because we should not miss the residual risk factors among the diabetic patient to going for the macroscopic complex, especially cardiovascular diseases as well as the this one stroke evolution. MicroRNA. Latestly, this plays an important essay. Also, I was discussing with Jayant Pandey regarding the microRNA. MicroRNA plays an important role in the identifying the prevalence of diabetes as well as the diabetes patient, because it's a non-coding, because there is good microRNA, there is bad microRNA also, because it plays an important role in grounding of the tissue, and this plays also important role in addressing both pre-diabetes and diabetes. So these are the various microRNA expression diabetes complication. I don't want into detail to the lack of time, because there are different microRNAs like 133B addressing neuropathy, sclerosis, atherosclerosis, prediction of nephropathy and retinopathy, and so on and so forth. So once again, type 1 diabetes biomarkers like T cell, we already know about the islet antibody, gas antibody, so on and so forth, but we should know about the T cell biomarkers and so on and so forth. These are various biomarkers among the type 1 diabetic population affecting both adults and children patients. Should not go for the diabetic nephropathy, neuropathy by means of early evaluating the biomarkers, very, very important. So, natriuretic peptide among the diabetic population like BNP and NT-BNP plays an important role to identify which patient going for pre-sodium ejection fraction or mid-ejection fraction like reduced ejection fraction. So, very simple data given. Bright natriuretic peptide among the diabetic patient can be easily identified to prevent the heart failure, because heart failure is one of the dreadful complications among the diabetic population. CRP, IL-6 as inflammatory marker. Previous speaker has clearly known the importance of inflammatory marker, because these are being provoked by the oxygen stress, reactive species. Already we have the Jupiter type data with rosuvastatin that with the statin along with the appropriate treatment of diabetes have been greatly halted the prevalence of cardiovascular impact by more than 28%, that is given by the Jupiter data. So markers for inflammation, IL-beta, IL-6 and TNF given by previous speakers. These are the data of the diabetic nephropathy addressing various hyperglycemia, inflammation, oxidation and so on and so forth. retinopathy data by ICAM, intracell adhesion molecule, we are there of artificial intelligence. We can easily identify the retinopathy at the early stage and also with the biomarkers also we can easily found. So these are the important biomarkers with the heart failure. With the heart failure we can see which patient going for inflammation, fibrosis, so on and so forth with the oxygen, this species, mitochondrial dysregulation or address the cardiomyocytes. These are all because mTOR gene, situin A, situin 2 and situin 3 plays an important role along with the sodium hydrogen exchange activation also plays an important role in addressing the both nephropathy as well as the heart failure. One second plasma activity inhibitor also plays an important role as an anti-inflammatory effect. So my dear friends, there are last two slides only. So genomics, microbiology, metabolomics, proteomics, different organic platforms have been coupled. We need coupled data to address the multiple level of researchers to find which patient going for pre-diabetes, and also we want to progress the mitigation from the pre-diabetes. The diabetes is very, very important. Day of take-home message, evidence shows that we gave the myeloma stages of type 2 diabetes provided us with the viable myeloma provides to postulate and instruments for the risk certifying. Very, very important. Risk certification is important among the diabetic population and pre-diabetic population. Also, the existence of such an instrument represents a powerful access that could decrease the disease burden. The future efforts would aim the biomarker because we are in the precision diabetology, we are practicing the precision medicine. Which patient need which treatment at which time at the right time is very, very important to address at the level of pre-diabetes to prevent the complication. Thank you for the opportunity given to me.
Thank you, sir, for the wonderful talk on this beautiful topic. So we'll just end the session and due to lack of time and hand over to the...
Only one question. Beautiful presentation. ASAN date, which is a biomarker, can be applicable in our day-to-day clinical practice.
Recently, Professor A. Ramachandran had given a talk recently before a conference, 1 week before. Adiponectin plays an important role. Adiponectin is the only biomarker plays an important role identified at the level of pre-diabetes, both lean subject as well as the obese subject.
Yeah, well done.
Thank you.
Thank you, sir.